Good morning. This is Colette Nies, and I am here with Dr. Joel Dunnington, and he is a medical doctor and professor. Do you go by doctor or physician? Is there a
doctor?
Okay. And this is episode 10, I believe, 9 of Coffee with Colette, and we are going to be talking about the mass conversation as well as vaccines. Maybe touch on school openings if that comes up, and just the basic questions that the audience may have and that I've had over the course of this COVID situation that we find ourselves in currently in 2020. So how are you doing?
Doing well.
All right. So I met Dr. Dunnington, I believe through you are a Texas Master Naturalist president. And
yes, that's right.
Where I was first introduced to you. So I'm going to give a little background. He went to medical school at UT Houston, surgery internship at Texas Tech, University Health Science Center, and radiology residency at UT Houston. He was an assistant professor of radiology at Texas Tech Health Science Center for 3.5 years. And went to UT MD Anderson Cancer Center in 1998. He became a tenured professor of diagnostic radiology. It was there for 26 years. He was the director of GI radiology and section chief of body imaging. He was chair of the faculty senate twice and chair of the UT System Faculty Advisory Committee. His main area of research was cancer prevention, and as a tobacco control activist. He has helped Houston, Sugar Land, Missouri City, and New Braunfels go smoke-free. And he was on the Texas Medical Association's Council on Public Health for 9 years and a consultant to the council for another 10 years. He was also the chief consultant on the Texas tobacco lawsuit. And he sits on the National Board of Americans for Non-Smoker Rights. And he retired to New Braunfels in 2014. Y'all, he sent me his CV, and the amount of committees and lectures and awards are impressive, and as an academic, very humbling. He received Radiologist of the Year in Lubbock, cum laude award in scientific exhibit, certificate of merit, Frank Weber Award by the Texas Medical Association, the Margaret and James A. Elkin Jr. Faculty Achievement Award in cancer prevention, the Samuel J. Hassenbach III MD and PhD PRS Leadership and Institutional Service Award for UT MD Anderson. You got one of the best doctors in America. And then what's really interesting about in this CV, it says ... and others I do not remember, which I think is really comical and just impressive. And a lot of those awards, I'll be honest, I don't know what they are. I consider myself a researcher, but obviously I'm not a physician. So
you'd be a little careful of those best doctors in America stuff, because I was, according to that group, I was the best doctor in New Braunfels, where I never practiced in New Braunfels. So you have to be a little careful of those
Oh,
things.
wow. Check that out.
Yeah.
Well, is there any, I usually ask, is there anything I left out that is important? There's a lot I left out on your bio. However, is there anything that that you'd like to highlight that I didn't touch on?
Well, one thing is I moved back to MD Anderson and right after Christmas in 1988, not 98.
Okay.
I don't know if that was my typo or you. I'm not sure.
No, it's probably
but that's
probably
it.
me. And one of the things I ask everyone that comes on here is to kind of tell me a little bit about yourself personally, like why you went into medicine, kind of where you grew up, and what are your pronouns of choice?
My pronouns of choice. This is the first time I've ever been asked that, I think. I guess, I don't know, I went into medicine. I have a degree from Angelo State University. I had a double major, biology and chemistry. And I'd always kind of liked, medicine. And so I applied and got in.
Mm-hmm.
So, and I thoroughly enjoy it, especially the actual practice of medicine, the clinical practice. Not so much the paperwork and other things, but the practice of medicine, take care of patients, I love. And I put that stuff in there about Council on Public Health and things like that, because most people don't think of a radiologist as being a public health physician, but I have a lot of experience from the Council on Public Health and doing my tobacco stuff and cancer prevention stuff in public health. So I do know a good bit about public health, not just radiology.
Well, I remember when this coronavirus kind of first hit in February and March, and we had a conversation, and you talked about, look, I was at, MD Anderson and it was your job to keep people healthy that had been immunocompromised, and the aspect of mask wearing and how important it was. And you were very vocal to city and county government from the beginning about the importance of protecting people publicly as well as yourself. And I want to thank you for that.
Thank you. I think it's very important. And I think, it's the time not to be selfish. It's to consider the people around you. You never know when, your neighbor, your friend, whoever, because I don't always talk about it, have been at MD Anderson, have got a leukemia or lymphoma or something where they're immunocompromised, or they've just had chemotherapy, and just, you never know. And that mask you're wearing is protecting them.
And I've heard a lot about this exposing people who didn't necessarily know they had complications to health.
They don't always know.
Mm-hmm.
And obesity and diabetes and underlying conditions like that, smokers have much more difficulty handling this virus once they get it.
Right. And then we have, I'm going to put it out there that, that African Americans are 2 times more likely to die per their share of the U.S. population. And then Hispanic or Latinx persons that do not identify as white are 4 times more likely. And there are discrepancies due to that. I believe 48% of cases and 9% of deaths have no race tied to them. Right. And this is since May, so some of the data may have changed, but it seems like every state has its own system of data or lack thereof, and it makes for this to be highly confusing to the public, and even for academics or physicians to know what data to look at. And I know you've given me quite a few resources.
Yeah, that's a real failure of the federal government, not using their actual book they have on pandemic planning, epidemic planning, that's updated every year or two and has been for many years. They just kind of tossed it in the trash can. And there was no central database set up. The database to collect a lot of this information was one they've been using the CDC for years for a number of different things, for influenza and some other stuff. It really wasn't set up to actually collect all this data on positives and the different types of positives and hospitalizations and what's considered a death and what's considered a COVID death and what's considered a COVID associated death. And, there's a whole bunch of those things that should have been set up at first, right. That this is how we're going to collect this. And we're all going to do it this way. And these are the definitions we're going to use. And everybody's going to have the same information. And they didn't.
Why do you think that is? I'm going to ask the tough questions, right?
Oh, I'm absolutely sure it's politics.
Yeah.
Well, there's 2 things, actually. One is politics out of the White House. The second one is we have been robbing our public health infrastructure for years, especially Texas. A number of county and city public health agencies have closed to save money, to rely on the state's regional public health infrastructure to take care of them. So they cut all those people. And then the state has, I've lost track of how many times the state has changed the Department of Health and Human Services over the years that I've been a physician, and changed it back and forth, and how much authority the Commissioner of Health has under each one of those reorganizations. Mm-hmm. And people have left, and they've cut the amount of people who are in those areas collecting the epidemiology and the information and stuff. There are not enough people to go out there and be contact tracers and do stuff like that, especially in this epidemic.
Well, I remember when I was with National Association of Social Workers, one of the things that I would testify in front of the House and Senate on was the lack of primary care physicians. This was, I believe, from 2008 to 2012. So the data is a little old, but then I think there was 30 to 31 counties in Texas that didn't even have one primary care physician.
Oh yeah.
And
a bunch of them don't have hospitals.
Right.
And a bunch of those counties, there's like 60, I think, that don't have hospitals,
So, I was going to begin when we talk about vaccines to inequities in healthcare. So, but this leads into it a bit. And so obviously there's inequities in healthcare. We have poverty and health discrimination. We have trauma and epigenetics, with the utilization of healthcare, and then the trust issues that different people of color and whites have on the ability to access healthcare on their behalf. We have essential workers that are more likely to be persons of color working in healthcare facilities, in the sense of particular jobs in factories, public transportation, farms, grocery stores. We have wealth gaps and educational barriers. We have living situations where some racial and minority groups live with more people in the home. We have unhoused populations. So there's so many levels to health disparities in the United States and in Texas, and the complexities that are around that. And it seems that we can't even get a cohesive understanding about something as simple as wearing a mask.
No, and you left out one of the most important, which is Texas has the largest uninsured population in the country.
Right. Yeah.
Which figures into a whole bunch of what you just said.
Mm-hmm.
If you don't have money in insurance, you're not going to get tested. You're not going to, go to the hospital. You're not going to, take care of yourself as well, because you can't. You don't have the resources.
Right.
And oftentimes when you're working in jobs that require you to be at work all day, you can't even take off to go wait in line 10 hours to get your COVID test.
Right.
You do that, you lost a day's work, day's pay, even if you do have a job.
To access to voting.
Right.
It's a whole nother ballgame.
Whole nother ballgame.
I've read some things that also about cities where you have, especially when you have like the Flint water crisis, and then also in North Carolina where people don't have access to clean water. And so how can you be expected to even wash your hands or get clean if you don't have access to clean water? And that's just something that I think a lot of people may not even realize it's going on continually in this country. I remember when I worked in Del Valley, there were areas of Del Valley that didn't even have access in unincorporated areas.
Yeah.
So we're going to move into masks, and I'm going to ask some questions. I presented this on Facebook to ask, I kind of put it out there to see if anybody had questions. So those are kind of going to be mixed into our conversation over the course of this Coffee with Colette. So
did you send me my Starbucks?
I have mine now. So could you talk a little bit about mask wearing? And I know it went from, in the beginning, and correct me because I'm not a physician. So it went from the way it spread, and then was it May or maybe in the end of April that it went to, okay, wait, this is aerosol as well. And so the kind of changes between how that affects mask wearing and if you're pre-symptomatic or asymptomatic, and how the importance of mask wearing there as well.
Well, I think when it first started, I think both the CDC and the World Health Organization both kind of downplayed mask wearing because they were afraid that masks would disappear off the shelves, and that health workers who are most likely to be exposed would end up not having masks or other personal protective equipment. And then again, our federal government has failed in producing that or stockpiling enough of that in the first place, or ramping up production, as of January or February to actually produce more so that we would have them not rely on just China or Vietnam or somewhere else giving us part of theirs, But I think at first they were worried that was going to disappear and healthcare workers were not going to have them. Because I think most of the virologists and the epidemiologists knew that this was probably airborne transmitted, but they stuck with the story of washing your hands and not touching your eyes and stuff, which is still important today, not to do that, but not to touch your eyes, but to wash your hands all the time. But probably April or so, you started getting some reports in from, there was Wuhan, there was a restaurant where one person was infected and it infected another 15 people around in the restaurant. From air conditioning circulating the virus and aerosol particles. Then there was the choir practice in Washington State, where one person infected in a 2.5-hour choir practice infected 57 people, and 2 of those died just in 2.5 hours. And so I think then they begin to see more, this is more of an aerosol type of virus and is able to be acquired in the air. And so I think that's when you first started seeing the mask being more and more promoted. I've been wearing my mask since, probably February, because I figured it was, and so I think, if somebody sneezes or coughs, they send droplets and aerosol particles from 15 to 26 feet. And this is from actual experiments. And so when you're talking, you send them 6 feet. And so this 6-foot social distancing is probably on the short side. You really should be doing 10 feet or more. But if you're wearing a mask and then you cough or you sneeze, most of that is contained in the mask, depending on how well the mask is formed, what type of material you're using. But it's, and the better the mask, the better it prevents that spread through your mask if you sneeze or cough, or sing or yell. So that's one of the things important about choirs and churches is singing seems to be a very good mechanism of spreading coronavirus. Yelling's the same thing.
For preachers that yell.
Yeah, or football games,
Right. So, they had Lake Travis opened for football practice this summer, and within no time, 12 players got infected, and so they cut it out. But we looked into. I was on the reopening committee for my church at New Braunfels Presbyterian, and we really looked at that choir study. And then you sent me a lot of data, which I'm really appreciative for. And I will, if you don't mind, I'll ask your permission. If we could, I'll put a link to this information, if that's okay.
That's fine.
For about the vaccines and the mask below when I upload this. But you were saying that you have 18 times more likely contract the coronavirus indoors. And I saw this one, and maybe it wasn't the SARS, maybe it was the SARS, it had somebody on the first floor had it. And
Well, that was actually an old TB case. Old
oh,
tuberculosis
okay.
case. Somebody multiple floors above had it and spread it to multiple floors below.
Right. And then
so some of those things can depend on your air conditioning system. And I fully expect in the next several years you're going to see changes in the air conditioning systems and the HVAC systems in America with more HEPA filters and more ultraviolet lights and stuff like that to try to cleanse the air better,
Which I'm sure is needed anyway, because you may know this, like the differences in like a hospital HVAC system as opposed to just your normal everyday.
In certain areas, I'm not sure all hospitals have as good as what they should. Some areas are much better than others, like ORs, ICUs, they tend to have negative pressure and more filtration and more ultraviolet light use and stuff like that of cleaning the air, but not the whole hospital usually.
I had a job once when I was in Austin in college, and that's just like, I was like, I think 19, where I worked at Applied Materials, and we made computer chips that made computer chips.
Yeah.
But we would get completely gowned up with everything on, gloves, the booties, and we would go through this like blower, and then like almost like a vacuum, and then go into the room so there would be zero dust in that entire, like where all the lasers were working, and it was like pressurized, and it was very surreal. That's a side topic, tangent. So I had a question from Linda Legler asked about, are homemade masks better than paper masks?
We'll go down the list that I put together for you. The best is that suit you see in some of the movies, Contagion and stuff like that, where they're in a biohazard lab and they have a complete face shield, complete suit, everything's taped. They get their oxygen in a hose from the back. That's the best. Of course, in 100-degree Texas heat, that's going to not last too long. After that are the N95 masks, which are supposed to be, and there are actually some N99 masks too. But the N95s are designed to take out most of the particles, and that's the best. And there's a KN95, which is a Chinese version of that, which is approved by the Chinese government, which is, when they're made correctly, as good as the N95s. But the FDA has found that some of those have not been made as well and have pulled a bunch of those off the market.
So what does the K and then the N stand for?
K means it's from China. I don't know why it's K. N is just, I don't remember exactly why it's called N95. It's to remove 95% of the particles of a certain size.
Okay.
And then surgical masks are probably next. And then after that, the cloth masks, especially the ones that are kind of more cone shaped and fit your face well, then that's what you want, is something that fits around your nose so it doesn't fog your glasses, but also comes in close around your face so that when you exhale, it goes through the mask and not out the sides. And then after that, you have the cloth masks that have the air valve on them. Those are designed for construction. They're designed to keep out the construction particles, but allow you to breathe easily. So those are not good for coronavirus or other infections, because those valves allow your aerosol to go out when you breathe out. So it's not protecting the other people.
It's more like for like sawdust and
from doing sheetrock and asbestos work and things like that, it may work, but not for infectious diseases.
Okay.
And then kind of the last are the ones with just handkerchiefs, or the big Texas handkerchiefs or something around your face, but they're still better than nothing. You know, any sort of cloth covering is better. And for the ones that are homemade, preferably the 3-layer ones work better than just 2 layers. And some people will actually put filters from their air conditioning filters. They cut them up and they insert those into their mask so that it even works a little better.
I've heard about charcoal filters. Does that even matter? I mean,
what kind of filters?
Like a charcoal filter? Because that's
charcoal doesn't do that much good for viruses. It does good for smells,
okay.
for odors and chemicals.
Okay. So I have my friend Molly made a bunch of masks, which I love. And then I have a few that I picked up also, but then a friend of my mailman gave me a mask that it has I love the Denver Broncos. And so it has the Denver Broncos logo. And I always wondered why people were like, oh, it's hard to breathe. It's hard to breathe, because I had always had masks that weren't, but that Broncos one is not made out of I don't know if it's out of some type of human made fiber that is not, it is hard to breathe. And it's like, you suck it in and suck it out. And I was like, I can't wear this like this. So it wasn't until then did I ever really understand, oh, wait, well, maybe people have the wrong mask, and that makes it more challenging.
Right. I think that's the most important part, because I have an N95 mask that's left over. It's a woodworking mask, and I had some of those. I sent them to my kids who are healthcare workers, and I've kept one, and Glenna had one. And that's easy to breathe through, but it's an N95 mask. So it has to be made correctly to work correctly.
Right. And one of the things that for me can be kind of deceiving is because the masks that you get, it's say Walgreens, those little paper masks, look like surgical masks, although they're not. And it seems like I see a lot of people just have one dangling from their ear.
Right.
Or they have it on and it doesn't go over their nose, or they have it where it's not fitted. So
if your nose is hanging out, you're doing it wrong. Okay? Your nose should be covered. It doesn't do you much good at all if you're going to sneeze or cough or anything else if your nose is hanging out. And there's a nice meme on Facebook about that.
So my mother had asked a while back about her concerns about low oxygen or high CO2 when wearing a mask.
Yeah, that's a right-wing fake meme. That's just complete BS.
Okay. Well, thank you for clearing that up.
I never fainted during my surgery internship. I have surgeons who have been working for 30 years who have not fainted in an OR yet. Mm-hmm. That's just pure bull hockey.
All right. Well, okay. And so something that you had sent on feasibility and adaptations that I had, because I'm not any of these things, I had not thought about it. Even as a social worker, I tend to think I'm a little more aware, but so I'm glad you brought it up. And you talk about mask wearing, say with people that are deaf of hard of hearing, as well as people with intellectual and developmental disabilities, mental health conditions, or sensory sensitivities that wearing a mask may be challenging, as well as younger children having the wherewithal to wear a mask all day. I mean, and if it causes breathing, like when you're doing some kind of physical activity, I think Holland had a study on people riding a bike and them sneezing and how far it traveled. Because Dutch culture is like everybody rides a bike. I mean,
everybody's on a bike. That's right.
And then one of the things that, and then like when you have occupational hazards to wearing masks, they're what do you? I know that was kind of broad, but
right. if you're working in hot places and you're sweating a lot, once you get that mask wet, it doesn't work very good, and it makes it harder to breathe for. So you either change it out for another one, or you're going to have to figure out another thing to do when you're working in those situations. But there aren't a lot of those, but there are some. And when I'm out working, like doing the butterfly surveys at Guadalupe River State Park, and we're out there walking a lot, and it's a hot, humid day, and my mask does get kind of wet. It makes it harder to breathe while I'm doing that.
Mm-hmm.
And that's why I usually wear my N95 and not the homemade mask for that. But my N95 is getting a little old. My one mask. But yeah, I said I came across that off the CDC site, and one of these is when you're considering school openings. These are those special ed kids, or a lot of these. That are they going to keep their mask on? While they're in school,
Mm-hmm.
or not? Depending on.
Especially when you have we have such a high rate of autism.
Yeah.
A lot of children or adults with autism have really severe sensory issues.
Depending on which ones. Yeah, that's right.
And so
little kids, my grandkids wear theirs. They're from 3 to 7, the Colorado ones. And I know they wear theirs when they go out. But on some of those little kids, it's going to be hard keeping them on their faces when they're in kindergarten.
Mm-hmm. And so I ran into a friend who was I was leaving HEB. This is like a month ago. And we got into a conversation, and he had mentioned that he said that he gets really claustrophobic, and that his anxiety and panic attack, it escalates into panic attacks when he has a mask on. And it's hard for me to understand. My first inclination is to doubt the efficacy, but I know that people have challenges that I may not understand. And so could you speak to that?
There's some of those.
And then people that use that as an excuse.
If they're that bad, maybe they need a little Valium during their day, just so they can follow the rules a little bit. If they're that anxious. I mean, there are people like that are that anxious, but I think by far, there are far more who use those excuses to be dirtballs and not wear their mask in public. Because it's a democratic thing to do. Mm-hmm. I'm sorry, it's been politicized so much. The new study just came out. It was like 85-90% of Democrats wore their masks, and about 30% of Republicans wore their masks.
And the thing is that the Republicans that I know that are healthcare workers and nurses and physicians are unified. Wear a mask. Yeah, I mean, right. And so that's why it's so frustrating, is to say. I mean, that's not even the right word.
And if they're my age, they really should be wearing masks, and they want everybody else to be wearing masks, because they usually have at least one underlying health condition that makes them more susceptible to getting severely ill.
Right. Mm-hmm.
So I do.
We're going to kind of move into the aspect of vaccines. And just so you know, there's all these sites on that Dr. Dunnington sent me about masks, about sneezing videos, all speech, choir, all these studies that I will upload and link to. And so to begin the talk and efficacy about vaccines, I do want to speak a little bit to there is, I heard I don't know if it was on NPR, or if it was some other podcast that I was listening to, and it talked about the mistrust of vaccines. And while I don't want to get deterred, but I do want to give voice and rise to just kind of the history of kind of a little bit we talked about before about mistrust, the history of inequity in this country. I mean, there's the Tuskegee Project in 1932 that went on until 72 on the aspect of syphilis and black men or sharecroppers and how that was passed on and without curing them when they could have, or treated, I should say. The history of undocumented people of color and poor whites and minorities, unmarried mother, differently abled, and those suffering from mental illness, with Native Americans on forced sterilization. Lakota, a historian, almost 40% of women. And that is not necessarily just vaccines, but I'm talking about mistrust. And this is not to undermine or make light of the incredible wisdom and strides that medicine has made. I just want to bring awareness, and then the 1927 Supreme Court case of Buck versus Bell, which was basically the American eugenics movement, that where there was 70,000 forced sterilizations that were state mandated for deaf, blind, diseased minorities, persons of color, poor whites in poverty, and minorities, and promiscuous women. And so we do have a mistrust of medicine and vaccines for a lot of different reasons. And I just want to bring awareness to that. And it's not going to be solved in this one, and that the mistrust comes from a long legacy. But there are, the flip side of incredible advancements in science and medicine as well. So just to get that out there. And I would like for you to start on the aspect of, let me tweak what I was going to say. So the NPR article or the podcast talked about, with the flu vaccine, there's only about 40% of Americans that take it. And that brings up not only mistrust, but just the maybe misunderstanding of what herd immunity is. And whether those two relate, I don't know. I had heard that if this vaccine, which I'm not saying it's the flu, by the way, but if we can't even get people to take a flu vaccine, how are we going to get them to take one if they don't even wear a mask? So there's all these,
Yeah.
And I know I spoke to a lot to that, but.
You're correct. And you're correct with your long line of public health and medical failures of things that we should never have done to people that we did, and that everybody needs to know that. Hopefully most of that has changed, although I'm not sure all of it has. But now we also have two different political parties seeming to put out different healthcare advice for this disease. And some of it is true and some of it is absolutely untrue. And so maybe we're just continuing with that long line of problems you said that we had. Now the problem with flu vaccines is there's multiple strains of flu, mm-hmm. and every year they get together and plan which flu vaccines they're going to put, which flu types they're going to put in that vaccine for the next fall. And they have to plan that 6-8 months in advance. And so they throw the dice and they hope they get the correct ones that match the outbreaks for that fall. And that doesn't always happen. So sometimes the flu vaccine is 90% effective against the flus that year. Sometimes it's only 30% effective against the flus that year. So it depends on how you do that. If you take a flu vaccine every year, the likelihood that you will have some immunity built up to one of the strains that is not in the flu vaccine this year may make it so that you have a milder case of flu that year than the other individual who has never taken a flu vaccine. So it's important for that. So for the coronavirus vaccine, number one, can they even make a vaccine that works?
Will you start out by kind of giving you had listed like the phase 1, phase 2, phase 3.
Development, yeah. So the first, for developing a vaccine, so the first thing is you have to isolate the virus. And the Chinese did that. I think they released it on January 8th, the full genome, and they released it to the world so that all these labs could start working on vaccines. And then it's necessary to identify the proteins and the sugars that are the most, well, you have to decide from, once you've identified that virus, what are the key parts of that virus that make it infective to your cells. And so, because the whole thing may not be infected, there are only maybe key little parts of that virus that are the ones that are allowed to go into your cell and do the replication. So you have to figure out which one it is. And then you have to figure out which proteins or sugars on those that you can develop a vaccine that'll block. Okay, and so, and which one's the most immunogenic so that it gets the biggest reaction in your body to produce the antibodies to it. And then you have to design and produce a vaccine. And sometimes they also use an adjuvant, which is an additive to the vaccine that makes you have a little bit more of a reaction to it and hopefully develop a much better immune response to it. And then you test these vaccines in preclinical studies in animals and to see if you can induce an immunologic response in these animals. And then if you get that and it's working and looks good, then you do phase 1 clinical trials where you do some tests on human guinea pigs to make sure, to try to decide what dose is best, how often to give the dose, and whether they have an immune response or not. And it doesn't cause too bad of a problem, too bad a reaction to the patients. And then phase 2, you make it so if phase 1 works and you don't kill too many people and they don't have too bad of reactions, then you move on to phase 2. And phase 2 clinical trials, you enlarge the number of people and you get a more diverse population to see if it works in different populations, to see if their immune response is good or good enough to protect them from the virus. Because a lot of times folks that have their immunologic compromise don't react well. Older folks don't do as well with vaccines. But if it works good in this phase 2, then you move on to phase 3. And phase 3 trials, a much larger group, like 30,000 or so, a much more diverse population of age, race, and other things, should make sure it works throughout the whole population and you're not leaving holes. And then, so say it works, somewhere along this timeline, they're going to have to start ramping up if build facilities and stuff to use to actually make this once they get it. And so, if you're going to give 7 billion doses of this vaccine around the world, you're going to need some little bottles. You're going to need to make those little vial bottles, the glass vials, and the stoppers that go in them, and the hypodermic syringes to give them. And so I don't think anybody in the world has a stockpile of 7 billion of those little vials. So you have to do the pre-production and get this ready. The problem with pre-production for actual manufacturing the vaccines is that they have like 5 different, well, there's about 6 different types of vaccines you can make. And on the ones that are the top ones right now that they're funding, 2 of them are messenger RNA, and 3 of them are recombinant with other viruses. And then there's some others in development that are inactivated whole viruses. Some just have parts of the sugars and proteins that they're using. So there's a whole bunch of different ones that there's like 140 different vaccines in development around the world right now.
To give for the I'm going to jump in there real quick just to say, like, for the audience, Dr. Dunnington said that, let me know that there are about 6 types of vaccines. You have live inundated vaccines, inactivated vaccines, subunit, recombinant polysaccharide, and conjugate vaccines, toxoid vaccines, genetically engineered RNA or DNA. None have been licensed before. And then replicating recombinant vector vaccines.
Yeah, there's probably a couple more I don't know about. But the RNA and DNA, 2 of those that are in the top 5 right now who are getting money under the warp speed development, that's their name, not mine, are RNA vaccines that have never, ever been licensed before. So, 1, do they really work? 2, are they really safe? 3, what extra hoops are they're gonna have to jump through to get approved by the FDA? Right. We still don't know all those answers yet.
Well, and so just to back up a little bit, the goal of a vaccine would be to combat pneumonia and to stop spread. Is that for all the people that are looking after this, or is that true or not true?
The vaccine is so that you don't get COVID to start with. Okay. So you don't even get a mild case. You don't get the pneumonia. You don't get anything, hopefully. Now, there will be some people who probably will not have a good response. Maybe they have a 90% response. Maybe the people, 90% of them will respond to the vaccine and develop enough immunogenicity that it works. But there may be 10% or 5% who do not. And so those people may still get infected by the virus. And so you have to balance these viruses of how big of an effect they have on the population and how few of reactions they have. Because if you have too many reactions, then a lot of people may not take it in the first place.
Well, that was one of my questions is so if you have people that are immunocompromised already, or people with, stage 4 cancer or liver disease or kidney disease or heart disease, all these excuse me, I just spit everywhere. See, I should be wearing a mask. That have these underlying conditions or major health, people that are more likely to get it and then spread it, wouldn't they be the most likely to have a vaccine affect negatively?
It just depends. It really depends on what type of condition and what type of virus. I mean, what type of vaccine. Because some people, immunocompromised people, can often not get one of the vaccines that use an attenuated virus. That's why some people can only take the polio shot and not the polio sugar vaccine.
Oh, okay.
Because they will still get polio from the inactive component. And other immunocompromised people do the same with some of the other vaccines that are made out of attenuated viruses. And so they have to be careful which ones they take.
Okay. So there's a couple of people that Anna Gibbons asked the question on if you could give a kind of rundown, and you've spoken to this a little bit, but the pros and cons of vaccine administering.
Well, I'm an absolute firm believer in vaccinations. Vaccination is either the number 1 or number 2 most important public health effort we've done in the last 200 years. That or water and sewage, clean water and sewage. It's back and forth of which one really saves the most people. Those are the 2 biggies in public health. It's clean water, sewage, taking care of sewage, and then vaccines. Vaccines have prevented hundreds of millions of deaths around the world. and there are actually papers out there. I didn't include any in the list there, but there are actually papers out there that will give you an idea of all the vaccines that you and your kids are getting every year, and what was the prior number of deaths from those every year before there were vaccines, and just to show you how many deaths and disabilities are prevented every year from all these vaccinations. You know, polio, not everybody died of polio, but a whole bunch of people are disabled by polio.
Right.
You know, one of my friends who's, I think, a little older than me actually had his leg amputated because his post-polio syndrome was so bad that it affected his lifestyle and had to have it removed. I have a number of other friends that I used to work with at Anderson that had post-polio who were older than me who, you know, were disabled from it, you know, and there's a late polio syndrome where, you know, those people have multiple problems later on down the road, you know, when they get up to older age.
Well, what about the fears that people may have? And I honestly I just wonder about a vaccine that's pushed through so fast, and, you know, maybe some hesitancy that the American public may have about a vaccine that's pushed through so fast.
Well, I worry a little bit too about it being pushed through so fast. I mean, I really want to make sure that,
like, well, I'll do the second round, kind of one of those, you know, or
well, the first round will go to healthcare workers and first responders. Those will probably be the first round of people who get it. But you know, there are papers out there that talk to you about the polio vaccine. When they first came out with that, there was a batch of that was really bad and had the manufacturing process was so bad. There were a lot of live vaccine in there, and they actually gave kids polio. There are some flu vaccines that have had severe reactions, and Guillain-Barré, about the time I started medical school, that was about 1976. And so yes, I mean, it worries me a little bit, this warp speed thing. It also worries me a little bit that one of the leading manufacturers, the Trump administration, took one of their investors and board members and put him into the administration doing vaccine development. That worries me too.
Well, okay, so
yeah, it bothers me a little bit.
So I have a question, and this is kind of revolves around the aspect of trust. So my foster daughter is 20 months. And when I've gone in, you know, during the scheduled times, some were kind of not followed a different route, but when she would get, because she's technically a ward of the state under CPS, I mean, I'm her guardian, but because she's the ward of the state, I've not been allowed to put her under my private health insurance.
Right.
Which, by the way, I don't have anymore now that the situation is the way it is with unemployment. But that's a whole nother ballgame. So, but for a long time, I was not able to put her on my private health insurance. And so she's on Medicaid. And so her pediatrician, when I talked to her about the vaccines, and was asking her about different brands, but you know, because I look into it, I want to know, I'm not anti-vaccine, but I want to know what the different brands are, and do I have a choice on which one she gets? And obviously private insurance and public and Medicaid have different vaccines for the same thing, for MMR, not MMR, sorry, what is it? MMR. And, you know, and so I had concerns about that. Like, obviously I'd want her to get the one that the private health insurance gives. And so what is that going to look like if this, what does it say when we have different ingredients for people that are poor or don't have full access to maybe a better version of health insurance? What will that look like when it comes to, I mean, and all this is maybe shot in the dark, but what would that look like for people that don't necessarily have access to the vaccines, because you know they're going to be produced cheaper for people with Medicaid. I mean, it happens. It seems to happen with all the other ones, so I don't see why it would be any different.
I don't know what they're going to finally do with these vaccines and how they're going to pay for it. If they're going to pay for everybody to have a vaccine so that every one of them is free or not.
Mm-hmm.
It's hard to tell. A country that considers health care not a right can't call itself the best medicine in the world. I'm sorry, that's just true. The rest of the industrial world seems to have no problem taking care of all their folks in their countries. And if you look at their numbers, most of them are doing a heck of a lot better than we are in COVID. We're kind of leading the world right now, COVID. Like we have a quarter of all the deaths in the world for the United States.
With only like 4% of the population
right.
of our country. Like that.
So some of that needs to be fixed. But I'm not sure how they're going to do that. I'm not sure which one of these vaccines is going to win the race. I don't know if multiple ones of these vaccines in development will work. And so you'll have multiple vaccines to choose from. I can't imagine every one of them will be equally as effective as the other one, since some of them are definitely different types of vaccines. So we'll just have to see. And a lot of that will have to come out after they do these studies. But I imagine they're probably going to have to do, a free vaccine for everybody and just pay for it. Because otherwise you're not going to reach herd immunity for COVID till you hit 65, 75% of the population infected. And right now, maybe we have 30 million people actually infected that we have, a lot of those we haven't tested. So we still have a long way to go to 300 million. And so by the time we get there to 65 or 75% of the population with a natural herd immunity because they got the COVID disease, you're going to have an awful lot more deaths in the United States.
Well, would you speak a little more about herd immunity? Because it seems like herd immunity sometimes happens through vaccines, in the what? But you said 60 to 70%, right, for people.
Right.
However, if you have only 40% of people like 40% of people get a flu vaccine,
right?
Or like, how would you reach herd immunity? Because if not, it would take years and years, right, for it to. I mean,
maybe years and years. We seem to be moving up the scale pretty fast.
Those people
who get the vaccine will have herd immunity,
Right. And so,
and the ones who don't.
And how can you speak to how people? So what if you're a carrier, but you don't experience symptoms? How would you convince someone? Is it the greater good to convince them to get a vaccine even though they don't experience symptoms? Or that's a little bit confusing to me.
Well, I mean, a lot of this disease is still confusing because there have been multiple papers out trying to figure out how long antibodies work in those patients who have been infected.
Mm-hmm.
So there seems to be a different antibody response for those who have had, asymptomatic or very mild infections compared to those that had, were really sick. Mm-hmm. So in 6 months, if those people are reintroduced to somebody with COVID, do they have enough antibodies they'll knock down the disease, or do they not have enough antibodies and they'll get it again?
Mm-hmm.
We're still not sure. Coronaviruses, historically, the ones that cause colds and stuff like that, you only develop immunity for a couple of years and you seem to lose it. And so you get it again. And so nobody's quite sure on this one if once you get it, are you immune for the rest of your life?
Right.
Or are you immune for 3 years? Or are you immune for 6 months? And nobody quite knows that yet, how that works. And nobody knows for sure on these vaccines if they're good for life or if you have to get one every year,
like a booster or something.
or a booster every year, or every 3 years, or something like that. I mean, these are still all open questions on COVID-19.
So I have a question. My friend Trey Hager from Iowa asked, what about people that are on anti-inflammatory medicine like Remicade or Humira? I don't know if I'm pronouncing that right. Do those meds put them at a higher risk?
Yes.
Okay.
Yes. Most of them, not all of them maybe, but most of them, yeah. If you're on methotrexate, you're on some of those things that mess with your immune system, you're probably more susceptible to getting COVID and to have a more severe infection.
Well, so what about the aspects of what's kind of been in the news lately, or not lately, a few months ago, with the hydroxychloroquine and that whole situation?
Let me follow up on something on that other one. Those people who are on those drugs, that's another thing that has to be figured out with the vaccine trials. Do those people respond to the vaccination as well as people who are not on those drugs? So that's still another question to answer. So hydroxychloroquine doesn't work.
Well, Kate, who was it? Kay Holt and Ashley Alsop asked kind of the known facts around hydroxychloroquine, because there's an array of, I want to give a little backstory here on this question. I have a friend who has lupus, and that's one of the things that she uses to combat lupus, which for the public is an autoimmune disease. And she, at one point, before they figured out it was lupus, was on up to like 59 different medications. I mean, it took her years to get to where she's really only on one. And she said that when the current administration and Trump talked about, oh, just take hydrochloroquine, that her physician said, you need to go buy some now. And when she went to get her prescription filled, the person was like, this stock is dwindling fast because people are buying it and getting prescriptions that don't need it. And then there's people in, Arizona, New Mexico, a couple that died because they shouldn't have been taking it, and they didn't to take the right dose. And if you could speak to that on the controversy around.
So first of all, hydroxychloroquine and chloroquine are drugs that have been used for malaria for a long time. They're both, relatively safe. Apparently hydroxychloroquine is safer than chloroquine. There are some side effects with heart effects, with widening the QRS intervals and stuff. And, but it pretty well is a fairly safe drug. It's used in people who have lupus. There are some other rheumatologic diseases that also use hydroxychloroquine. There's some theoretical basis of why this might work with the SARS virus, because it has an ACE2 binding prevention in here. But that's a theoretical one. They've tried this in SARS. I think they tried it in Ebola also. It didn't work very well in those viruses either. And so, when they first came out, I said, there's a theoretical reason it might work. I have no problem with them trying it, but anything that should be tried like this should be tried in a randomized controlled trial. It should not just be willy-nilly private physicians handing it out to their patients saying, oh, go ahead and take this with a little azithromycin also, maybe throw in some zinc, who knows what else. No, these should be controlled trials so that we can actually figure out if this really works or not. And then once you do the trials, then you look and see, make sure the trials are good. And trials are not always good. They're not always designed good. They don't always accrue patients correctly. They let patients slip out the back door incorrectly when they write these up. So you have to be adept at reading these reports. But there have been, I think, now 4 randomized controlled trials of hydroxychloroquine that have all shown that it doesn't work. And so I think we have enough now that you really should not be giving it to people with COVID-19. It doesn't work. The other side of that is that when all these people were hoarding this and were using this, then the stock dropped for people who actually need it for actual diseases that it did really work for, like lupus and some of the other rheumatoid diseases. And so then those people couldn't find their medicines they need to function every day. And I'm sure, I haven't seen anything on the prices, but what do drug companies normally do when a drug gets popular and the stock gets low? What do? You know, they raise the prices, so they make a killing. You know,
what was it? That lawsuit that went on with the guy who had the what was it for insulin, and it went up astronomically. And
but when I see things like this from my years of working tobacco control stuff and learning about front groups and stock markets and all this stuff, I always look to see who owns stock in these things.
The money.
Who's going to make the killing off of whatever they're promoting? You know, because some of them just don't make sense. And some of them, when you have physicians who ignore the randomized controlled trials and are still promoting it out front, who are they working for? Who's making the money on this? You know?
So what we're going to, we're just to be conscientious of time, I'm going to ask a few questions about, and I know you're not an epidemiologist, but I'm going to ask you these questions anyway, just because I want to know your opinion. Not that you have to be one, but so Courtney McDowell asked, in the aspect of school openings, how can teachers best protect themselves and their own families if distancing and masks are not required or going to be enacted? Like specifically with Kamau SD here, there's going to be no distancing. The masks are not mandatory. The lunchroom, they're not going to be distancing in the lunchroom. I mean, there's a lot of concerns and fears, and rightfully so. So how can they protect themselves if those things are not?
Well, the first thing is I think kids should be in school, but kids should be in safe schools. And from CDC guidelines, they say not to open up schools if you have a high rate of transmission in your community. And Kamau is now like 14% or something like that.
It's 19.0.
19. Texas was 15%. You know, that's not 5% that the CDC suggested for opening. The last time I checked, the state capitol tours and the governor's palace tours were still canceled. The Republican and Democratic state conventions are being held virtually. Baseball fields have like 10% of the fans allowed in the stands, and one of the baseball teams just ended up with 17 players positive, the Marlins. So I think it's going to be very, very challenging trying to open a school. I would say if you absolutely have to open schools, you should wait till it goes below 5% in the community. And those schools should have masks for everybody, kids and adults. And, you know, I think it's going to be real hard to keep kids distancing, you know, just their natural behaviors. I think it's very difficult to keep them distancing. I think it's very scary to me of what's going to happen to our COVID positive numbers once school opens and all these little kids start transmitting it around. Because right now they have not been transmitting it since March, or in, you know, smaller amounts because they've been out of school. They haven't been interacting with their friends and stuff like that. You know, once they start getting it and transmitting in the schools and they go home and visit grandma or parents, they get sick. It's going to be very difficult, I think, to manage.
Well, and I wonder about, you know, people that, specifically teachers and workers that take care of like older parents, or there's a couple of teachers that have voiced some things to me about how they're taking care of a family member who is immunocompromised, who has cancer, who has, or they say they teach in Kamala ISD, but they live in San Marcos. And so, I mean, there's this travel and carrying, Hayes is even worse than us right now. So
right.
It just seems so complex, and there's a lot of layers to how to stay safe and have open communication. And what happens? Do you close the whole school down? I mean, did they have a plan? I know these aren't necessarily the conversations that you and I might not have the most data when it comes to like schools and those conversations they've been having. But I guess maybe to go back to Courtney's questions, how can teachers and best protect themselves when there isn't the distancing?
Well, first of all, there needs to be definite school opening CDC guidelines. Mm-hmm. And there are CDC guidelines which have not been massaged by the administration's, Trump administration's White House, as apparently the CDC guidelines were here recently. These should be developed and they should be used. This needs to be a coordinated federal response that feeds to the states, that feeds to the local. It should not be, oh, it's every state for themselves. And then the governor says, well, it's every county for yourself. And so,
well, then you have the state that's undermining local governments for making.
Right, absolutely. But, people who are Texans, who only think Texas, should realize that Europe, who has managed their pandemic, is opening schools back up. New Zealand, which has wonderfully managed their pandemic, has opened schools back up. Iceland has opened schools back up. Taiwan has opened schools back up. I didn't think Taiwan ever closed their schools. But then they have a PhD epidemiologist who's their vice president.
I did not know that.
Not a former tobacco guy who's our vice president. So, if you look around the world, there's a lot of those countries which are doing a lot better managing and opening up schools and opening up their economy because they didn't let the epidemic run rampant in their countries.
So do you think it's going to have to be the United States is going to have to finally do a complete shutdown? I mean, it doesn't seem like it's going to happen, but it's just.
I'm just hoping it doesn't come January 21st. That we have to shut down the whole country, Hopefully before that, somebody does something. The rest of the countries around the world have done contact tracing, have done, testing, have ramped up their testing quickly, mm-hmm. not just slow increase over the last 6 months like we have, that ramped up testing quickly like South Korea did, where they actually tested people quickly, contact traced whoever they went with, actually using phone apps to follow these folks and make sure they're staying at home. Mm-hmm. And they've kept their numbers much, much, much lower than the United States has.
Well, do you think that, I don't even know if it would be even feasibly possible for our county, but it seems like to me, if you're going to reopen schools, I mean, for people that are in person, that everybody should be tested. I mean, get tested. If you're positive, don't go. If you're negative, okay.
Because there's so many of those, and the younger you are, the more likely it is that your infection is going to be asymptomatic. Right. The younger kids below 10, even more so than the ones from 10 to 17 to 18.
And I was wondering that because they had that study, I don't know if it was in Spain, where they let the younger kids go back into school before because they were less likely to be infected. But then after a few weeks, it just crumbled because they don't know how to distance. And I wondered, is it because they're so low to the ground? That's probably no sign.
I was just saying, they're very handsy. They love touching
like
their
our president.
Yeah, I don't know if they get sicker any more often, but their illness is much less. They're not as sick if they're the younger kids, the grade school kids, than the junior high and high school kids. They apparently get sicker than the grade school kids do once they get it. I'm not sure if the actual infection rate is different in those two groups or not. I'm not sure if anybody else is.
All right. Well, I want to thank you for coming. Is there anything that you'd like to voice or say before we close?
I'm just hoping someday soon we'll have direction from the federal government on how to maintain this and actually produce enough PPEs for the healthcare workers that, you know, they don't have to wear a mask, an N95 mask for a week, you know, where it should have been thrown away after every patient. You know, that's just nuts. It's just crazy.
And also, just to end on maybe a level of hope, would you just say something positive or a bit of advice for people on the hope of a vaccine, or in just to say something to people that are wearing masks to encourage others?
There are multiple studies now that have shown that wearing masks, if everybody wears masks, the whole country does a lot better in transmitting the virus. If fewer people are sick, you reduce that R0 rate, the transmission rates. It's now 2.4, 2.7. You want to get that below 1. Once you get below 1, the virus kind of peters out in the community. And the only way to do that is wash your hands, don't touch your face, social distance, and wear your mask. The best mask you can find.
Well, all right. Well, I want to thank you, Dr. Joel Dunnington, for spending this hour and 15 minutes with me. I really appreciate it. I really appreciate your wisdom and time and candor. And thank you for coming. Thank you for meeting with me.
Thank you. You have a good day.
Tell Glenda, that I said hello. And today is your birthday. So I should have said that in the beginning, but happy birthday.
Thank you.
You're welcome. Y'all have a good one.
Yeah, you too.
Bye.